75-year-old woman is now post-operative day 1 after a subtotal colectomy. She is receiving morphine via PCA for analgesia, no basal rate, 1 mg IV with a 6-minute lockout and a 10 mg per hour max. However, the patient forgets to push the button and continues to complain of pain. The PCA is stopped and the patient is given 2 mg of hydromorphone IV. She becomes acutely nauseated, then desaturates and becomes apneic and bradycardic. After being bagged and receiving naloxone, she returns to her baseline mental status, but has a new oxygen requirement. Patient-controlled analgesia, or PCA, is an interactive method of pain management that allows patients to manage their pain by self-administering doses of opioid analgesics. PCAs can be an effective tool in reducing pain, but require expertise for safe use. Is a PCA right for my patient? If you're considering PCA for a patient, there are 5 critical assessments you should perform first. First, a physical and cognitive assessment. A PCA requires that patients are active participants in their pain relief, so it's important to make sure that a patient is ready, able, and willing to manage their own pain. To do this, initiate a pre-procedure cognitive assessment that evaluates the patient's mental status, level of consciousness, and cognitive ability. The patient must understand the relationship between pressing the PCA button and pain relief, the concept of dosing interval or lockout period, and demonstrate that they are physically able to self-administer a PCA dose. Second, is the patient opioid tolerant or opioid naive? An opioid tolerant patient is someone who has been taking at least 60 mg of morphine daily for a week or longer, or an equivalent dose. Equianalgesic doses include 30 mg of oxycodone daily or 8 mg of hydromorphone daily. For help on opioid equivalents, see the equianalgesic conversion segment. An opioid naive patient is simply one who does not meet the requirements for being considered opioid tolerant. Why is this important? Basal doses, defined as a continuous opioid infusion used in addition to the patient-controlled analgesia, increase the complexity of writing for a PCA, as well as the risk of opioid-induced respiratory depression. We do not recommend the use of a basal rate in opioid-naive patients. However, a basal rate may be required in patients with opioid tolerance. In these cases, a pain management specialist should be consulted, when possible, regarding the safest regimen for effective analgesia. Third, is the patient educated about PCA dangers, in particular PCA by proxy? Patient and family education is critical for safe, effective use of a PCI. Make it clear to the patient and all visitors that no one else should push the button and that they should alert a nurse if they are unable to control their pain adequately with PCA. Fourth, is our team capable of performing regular sedation and respiratory assessments? Sedation and respiratory assessments are essential to ensuring that your patient is not developing significant respiratory depression. Frequent vital sign and sedation assessments are required during the initiation or upward titration of a PCI. Patients must be in an area where these frequent assessments are possible by nursing. Several sedation scales are commonly used. We tend to use the POS in acute care areas since it is an easy-to-use scale specifically geared to opioid-induced sedation. However, sedation assessments are difficult in sleeping patients, and pulse oximetry and capnography are important adjuncts that will be discussed elsewhere. Fifth, are reversal agents available? Naloxone should be readily available for emergency reversal in patients receiving opioids via PCA. When a patient's pain is not being controlled with the PCA, or the patient is oversedated, ask the patient's nurse to query the device. This will help you understand how much of the medication the patient has actually received. The interrogation tells you the concentration and dose of medication that have been programmed into the pump, the number of demands or button pushes by the patient, and the total amount of drug received per hour. In the case of the woman described at the beginning of the segment, a PCA interrogation would have identified that the patient was not using the pump to deliver her pain medications. Similarly, interrogation of the pump can identify dosing errors or programming errors, which, when remedied, could control the patient's pain appropriately. Individual medication doses are beyond the scope of this video. We recommend the California PCA Toolkit as an excellent reference for dosing guidelines. Share this video with your team and help make sure that everyone knows how to conduct a pre-PCA assessment.